Welcome to the Golden Jubilee National Hospital, the home of the West of Scotland Regional Heart and Lung Centre. My name is Keith Oldroyd. I'm one of the interventional cardiologists. On my left is Dr. Stuart Watkins, who will be the first operator for this case. In the lab today we've got Karen, radiographer, Katie and John, cath lab nurses, and Douglas, our physiologist for the case. And we think we've got a very interesting case for you today, which has got a lot of the features of complex left main bifurcation and multivessel disease that we work with every day of the week. And I'm just going to hand over now to Dr. Watkins to describe the clinical features of the case.
Okay, so this is an 82-year-old gentleman. He came into hospital a week ago with chest pain and had a non-ST elevation MI diagnosed. His ECG showed some lateral ST depression and his troponin I was greater than 1,000. He's got quite a complicated background. He had PCI performed in 2006 to his right coronary artery for angina. He had a bare metal stent, which was a 3mm driver inserted at that time. History is also complicated in that he is on steroids. He has polymyalgia rheumatica and has been on low-dose steroids for some time. He's also had mesenteric ischemia roughly 2 years ago, requiring a laparotomy, and this was due to a volvulus. He has Raynaud's syndrome in addition, and a history of hypertension. So we're going to show you the images from his diagnostic coronary angiogram next, and we'll take it from there. So we've just engaged the left main stem, pressure's okay. So we'll take a spider here to start. Yep, 6,000 hip. Okay, iliocranial.
So you can see right away in the spider view that there's a tight lesion in the left main stem. And again, this time it's obvious that there is ongoing disease into the LED beyond the diagonal, with a very obvious myocardial bridge in the mid-LED. That's the iliocranial view. You can see the stents in the right coronary artery. The right coronary was widely patent on the angiogram last week, so we don't plan to have a look at the right coronary again today. And then that's obviously an ariocaudal view where you can see that this is a true 1-1-1 distal left main stem bifurcation, and as well as the LED disease, there's quite a lot of disease extending into from the circumflex into the first obtuse marginal branch.
Okay, good. So we'll take 2 BMW wires.
The strategy in this case is to place 2 wires, one in the LED, one in the obtuse marginal branch, and then start with the OM and reconstruct that back into the left main, and then do a culotte left main 2-stent bifurcation technique, and extending the second limb of the culotte down into the mid LED beyond the diagonal, but just short of the second septal.
So in intravascular ultrasound, you can see that distally the vessel is 3 millimeters in diameter.
So that's already quite helpful, because the original thought were that we might put a 2.5 in there, but clearly, it looks like it will take a 3. And that's clearly preferable if we're going to take this a single stent back into the left main. We can post a later 3mm stent up to 375, knowing that we're going to end up with a second stent in the left main anyway when we complete the culotte. So there's a tight lesion, as you can see, almost occlusive against the catheter, just for a couple of millimeters there. And a lot of plaque again. Probably some negative remodeling, a bit of calcium around about 2 o'clock to 4 o'clock there, but actually quite a well preserved lumen. Now a little bit more calcium. between 2 and 8 o'clock, but still a nice, well-preserved lumen. Now we can go back into, just across the ostium of the circ there, you can see the second wire in the LED, very, very tight across the left main and quite calcified, about 180 degrees of calcium. Now we're back in the left main, as usual, a large left main, and now we're back in the aorta. Okay. Isn't it?
Yeah.
So we'll pull back from there. ECG is still looking good. So the predilatation is facilitated IVUS in this case. We wouldn't go straight with the IVUS without predilatation because it's likely to cause a lot of ischemia. So it's a small vessel, quite a bit of calcium, a lot of calcium just at that point, more than 180 degrees. Oh yeah, we can see it. So now we are getting some anterior ST elevation if you see on the ECG. So we'll just let this complete. And we've almost got 360 degree calcification there for a short segment. I guess that's where we were struggling with a non-compliant balloon. Now as the IVUS catheter comes back towards the left main, we're starting to see a reasonable lumen. And then there's the circumflex at 6 o'clock with the wire, quite a bit of calcium this time between sort of 9 o'clock and 12 o'clock, and then that the severe distal left main stem lesion itself back into relatively normal looking left main. So do you want to just describe the Scoreflex balloon, Stuart?
Yep, so the Scoreflex balloon is very easy to deliver, almost like a cutting balloon. It has a titanium wire down the side. It's got a very short monorail section, and therefore your actual coronary guide wire, along with the wire which is attached to the balloon, you know, acts as a cutting balloon for calcified lesions. So it's a very useful tool when you have severe calcification, and if you don't want to go as far as using the coronary rotablator, it's a good way of cracking the calcification before you deploy your stents.
I guess the advantage of this strategy over rotablation is that we can maintain access to the circumflex.
That's right.
Whereas if we committed to rotablation at this point in this procedure, we would have to pull the wire from the circumflex, which, you know, potentially could be a problem.
Sure, I'll give some nitrates.
So Douglas, on IVUS run 1, can we have a length measurement from a decent landing zone back, let's say halfway into the left main? Okay, so freeze it there, Douglas.
There, maybe put a bootmark on there.
Mark there, and then drag it back. Rather than play it, just drag it back into. So keep going, keep going, keep going, keep going. So there's the. Go a little bit further. Go to the far right hand edge of the.
Yeah, further proximal, yeah.
Yeah, I mean that's fine there. We're back into the aorta actually. So back into the left. Drag it back into the left main, Douglas.
I think where you've bookmarked actually. On a touch. Okay.
Yeah, there, yeah.
Okay, yeah, bookmark that. Turn on bookmark lengths.
So it's saying 34.29 from 1 to 3.
Okay.
Okay, so 34 millimeters.
So then we take a 3 by 38 millimeter stent.
Okay, so a 3 by 38 synergy, please.
So this gentleman's high bleeding risk. He's 82. He's anemic, a hemoglobin of 122. Previous iron deficiency anemia. Synergy a good choice of stent for this?
I think it's a good choice. I mean, it has a biodegradable polymer, everolimus very thin strut. There is reasonably compelling evidence that it's a safe stent with a short duration of DAPT. We'll see more evidence for that in the coming months, one way or another, from the seniors trial. Of course, we've got a lot of experience ourselves from ideal left main of using synergy stents in the left main and stopping the DAPT after 4 months in the ideal left main trial. The OCT results from that trial will be presented at EuroPCR and the final clinical results sometime in the next 1 to 2 years.
So here's the synergy. You can see a lot of resistance at the ostium to the circumflex.
Even with the 7 French guide and a wire and the LED and the pre-dilatation with the non-compliant followed by the Scoreflex, there was just a little bit of resistance, but Stuart has negotiated that nicely.
Okay.
So now we've got plenty of the distal landing zone is obviously excellent here.
Yeah.
What we need to the problem in terms of a calot in this case is that the left main is actually relatively short.
Absolutely.
So
that may be quite a good position there.
Okay, we do a little
there. Do an acquisition.
Let's do an acquisition and see what that looks like. Okay. So that's pretty good.
Yeah, certainly distally looks excellent, and
happy to go there?
yeah, I think that's a good position.
Okay, so here we go. Okay, so 14.
Store flare up. So deploying there at 14 atmosphere, stent looks well expanded.
Okay, so the next step is proximal optimization with this stent. It's a 3038. We know that the left main looked well over 4.
Yep.
What would you like for the proximal
I think we'll take
optimization?
a 4.0 non-compliant balloon.
4012?
12 would be good. Yeah.
Okay. So this lab, as you know, has this PCI assist facility in it. So do you think there's a potential role now with the positioning the balloons for the optimization?
Well, I think we obviously want to make sure with the pot that we dilate all the way to the carina to ensure that when we rewire the LED, we don't go behind any struts. So it can be quite useful at this point. It's also going to be useful when we stent back to the ostium of the left main stem to ensure we've got complete coverage all the way back. It's quite hard sometimes to check that you are far enough into the carina for your proximal optimization. So what we'll do now is we'll do stent VesselVis, which is part of the PCI Assist software package, which is very nice software for checking exactly where our balloon markers are within the stent. So we're going to code in as much as we can around the left main stem here, just to check where the distal marker of our balloon is. So during this...
So is this with or without contrast?
It is with, yeah. So instructions come up on the left-hand side of the screen telling you when to inject. So first of all, we just do an acquisition, and then we'll be told when to inject when it tells us. So inject now, and stop. Okay. So we'll just wait for the images to come up on the screen. So you can see the proximal edge of the stent and our 2 circular balloon markers. And you can see here actually it's perfectly placed for proximal optimization. We're not all the way into the circumflex, we're right at the carina. We're covering back to the proximal edge of the stent. So,
and we're not concerned about the fact that we're dilating the right back to the ostium of the left main, because we're going to stent that with a second stent. Yeah.
So we're quite happy with the position of that. So we'll do a proximal optimization there.
Okay.
Obviously, we're not going to do a full post dilation. We've got up to 14 or so atmospheres.
So this is avoiding the risk of having a 4.0 balloon into the circumflex.
Absolutely.
Yeah. Okay.
We'll give some nitrates as well, just in case there's an element of spasm contributing to our lack of ability to recross here with a stent. There's 200 of nitrates are in.
I think there's an element of solid concrete here, Stuart, rather than spasm. But
well, we'll live in hope. Just wire down into the circumflex. That's very freely mobile. I don't feel like I'm behind any struts or anything there.
No, you'll get less friction on this wire anyway.
Absolutely, yeah. So I'm just going to come back. Same manoeuvre as last time. You see it's just popped up into the LED there. Again,
pretty easy. Crossed that, wasn't it?
Very easy, yeah.
This is a used 3012 balloon. It's not a new balloon.
think it's gone.
A little bit better than the other one. So that's crossed without it requiring the
Without
anchor
an anchor.
bloom.
Yeah, we've definitely
So
crossed
we
there.
dilate there.
Yeah, that's great.
So that's definitely better.
Just gonna nudge forward.
It
there,
did.
so,
It
yeah,
popped
slow
forward,
that
didn't
through.
it? It popped forward. Maybe you could see that in the
I
fluid.
think
There.
that suggests we're in a different cell.
Yeah, quite
I'll just
possibly.
come back a touch.
Okay, happy to
Okay,
go
yeah,
there?
go there.
We're just on the edge of the guide there. Okay,
Yeah.
that's good.
Take a little puff there, Keith. See where that is.
You
You
can
can
back a
come
little
back
bit
slightly
further, a little
more,
bit
yeah,
further.
Yeah. Happy
Okay,
there.
yeah, that's good. I think we're good at
So we're
both
still in a
ends
good-
there.
good
We're good at
position
both
at
ends.
both ends,
Happy to
so-
deploy there?
Yeah, that's great. Cool.
Okay. So we're going to go reasonably gentle here. It's a pretty negatively remodeled, even though it's only a 2.5 stent. That's 14 atmospheres. We're over the diagonal, and we deliberately haven't rewired the diagonal at the moment. So Stuart, what's the potential value of the PCI assist at this stage? Because we're about to place
Absolutely.
an overlapping stent to create a clot. So
I think the most important thing here is that we bring the stent all the way back to the ostium of the left main stem. There's nothing worse than landing slightly short and having to put double layers of metal, well, in this case triple layers of metal, within the left main stem.
Yeah.
So PCI assist is going to help us in that regard.
Okay.
It's also going to make sure it's a very calcified vessel. This.
So let's pop this in the middle of the screen and bring the shutters in, Karen. That's great. Yeah.
Oh, so this is a bigger stent. It's also going to help us make sure that we've got overlap with the stent that's already in there.
It's a bigger stent, and we don't have the we don't have the wire and the circumflex to support the guide.
Yeah. Slip across. Maybe not. We may need to place another wire back in the circumflex, see if that helps. This is a bigger stent though, not as long as the last one.
There you go. There you go. Excellent. So that's just the usual little bit of angle between the left
manipulation
and the stent.
And Professor's going to inject now.
That's what professors do.
Absolutely. You can see there. Actually, looks like we've got some overlap, certainly.
Yeah, so we've got plenty of overlap for sure.
Can we come back further? So let's just see from the stent vessel vis. You can see the two markers for our stent. You can see where we're going to have the double layer.
Yeah, that's very nice.
We can use the stent vessel vis here again just to be sure that we're in the right place.
Okay.
Inject.
Yeah, you're just above the diagonal.
So that's good. So it means we won't obviously double jail the diagonal.
Happy to go there?
I think it's pretty good there.
Yeah, I'm happy.
Good.
Yeah. Okay. So this is a 3.5/16.
Store flow.
Going in at 18 atmospheres. Looks well expanded.
Okay, and inject now. Okay.
Okay. You can see the outline of the stents very nicely, so that's excellent. We'll take it up to 18. That's a nice proximal optimization.
Great.
Okay, so now we're going to do a kiss. 10, 12.
12, yeah.
Okay, hit the acquisition. We're both on 12. Okay, that's beautiful.
So this is quite an important postulation. So this is the largest balloon that we're going to place in the left main stem. Very important that we get the carina completely here.
Okay.
So again, we could use our stent vessel vis, a little puff of contrast just to check where we are. So I need to come in slightly. So we're on the LED wire here. So to me that looks pretty good, but let's just see how it looks using stent vessel vis. So we're well coned in, and no problem. Okay, great. So we're going to acquire here. Professor Oldroyd is going to give contrast, and then we'll see how that looks. Might well be perfect. So you can see our balloon markers within the left main stem. You can see the new carina created by our two stents. I think that's perfect. I wouldn't want to go much further forward than that. I think that looks pretty good.
Yeah, no, that's excellent. I mean, I think that's a real nice demonstration of the fact that, you know, if you go too far, you will distort the new carina.
I think that's the beauty of stent vessel
Yeah,
is it,
that's in a real nice
you're
spot,
then
isn't
sure
it?
that you're not in the LED, because obviously we know the proximal LED is not 4.5 millimeters.
Yeah.
We know we're completely within the left main stem, and we're not going to cause any problems by going up here. So I think that's a good position.
Yeah.
So we'll post dilate there.
Okay.
So PCI Assist has got two components. It's got stent vessel vis, which we've used already, and now we're going to use stent vis.
So no contrast for this one.
No contrast for this. Again, similarly, we have to cone in around the stented segment. It uses the balloon markers in order to do elastic registration, which tracks the motion of the wire and also the markers on the stent. So already stent vis is on. So this is just an acquisition. It's around 30 frames of acquisition. That's all that's required.
So a couple of seconds at the most.
You can see there we're perfectly positioned.
I think you're in a great spot
there for post dilation. So we're not going to go crazy high here. Maybe go up to 14 or so. We know it's a 2.5 vessel distally. So post dilation there. Store fluoro. So it's hard to know if the ostium of this diagonal is okay or not. Keith, I think we use the QFR, then probably use the Comet wire to
just to confirm it.
Measure FFR.
Well, we're here,
as well.
yeah. Can I have a fluster then?
You can see it's such a big important vessel, it would be a shame to have a problem with it.
Yeah, no, sure, it's a very important artery and we're here anyway. For the sake of another few minutes, we'll just verify. We have some world-class QFR support in the cath lab today from Gerhard Koenig from Medis. And we're just going to ask Gerhard shortly which views he thinks would be best to assess the diagonal. Okay.
So now you have this view, and you can just move the rotation and angulation of your system and make sure that that orange circle is outside of the red circle, and that the orange line is more or less perpendicular to the LED.
Okay.
I did the analysis, and I started in the LED. The complete analysis of the diagonal, where I used some normal areas as normal parts of the vessel. It's a slight decrease of the reference diameter. The lesion, there is hardly any lesion, which is significant. The vessel QFR for the diagonal is 0.96. And that is the same for the fixed flow QFR, so that's the under assumption that we have a fixed flow through the vessel, an average flow. And I also did the frame counting QFR in normal angiogram. We come up to the same value of 0.96, so it's far from being significant.
This is quite a challenge for a pressure wire because we're in a left,
to the areal caudal to start.
we're in a left main bifurcation, fully stented, and so this is not straightforward. But we thought we would challenge the technology just to see whether it is possible to wire that diagonal through the long stented segment in the LED. Okay, that's
so
good.
we'll go to the areal.
So there you saw the wire crossing the left main into the LED.
Yeah, thanks.
And now we'll see if we can...
there you go.
Oh, in fact, it's crossed straight into the diagonal without
That's
any
obviously
problem.
a good sign, Keith.
That's a good sign. So and that's as far as we need to go to check the FFR across the proximal segment of the... Okay, so Stuart's going to just back off the needle introducer. I'm going to give a little flush, and we're just going to sit tight and see what we've got here. Now we have to recognize that the angiographic images of this diagonal were challenging. So we've got a PDPA of about 0.9. So I'm going to use high bolus dose intracoronary adenosine. So I'm going to give 100 mics in the first instance, just in case we get any problems with block. Just record, Douglas, please. Go ahead and record on the pressure wire. So we'll transduce our aortic pressure back on. Okay, so we're definitely getting an effect of the adenosine. So 0.87,
Yeah.
87, 87, 87. Okay, so pretty stable there.
Certainly not full limit.
Okay, so I think we've come to the end of this case now. We've used a lot of tools and techniques, which of course is the point of this session. We're going to close with a couple of final angiograms with the wires out. So we've given quite a bit of nitrate already. The guide's good. Let me just check the contrast. Okay, so that's pretty good. So we'll do this view, which is an areocranial. Yep. Okay, it's a fantastic demonstration of the bridge. Okay, and now, what do you think, caudal?
Yeah, areocaudal.
Areocaudal. Okay, good. Somebody's applauding in the background.
That's reassuring.
That's got to be a good sign. Okay, I think we're happy, Stuart.
He looks great.
Okay. Thank you again for being with us today for this live in a box case recorded at the Golden Jubilee National Hospital in Glasgow. I think we've ended up with an excellent result in a very, very difficult case. Just draw your attention to a couple of points. One of them is very low radiation dose of 350 milligray for this case, despite the use of the stent vis and the vessel vis, which is, I think very encouraging. I think hopefully we've demonstrated the value of both of those techniques. And I'd just like to thank the staff, thank Karen, Katie, John, and Douglas, and of course Dr. Watkins, who's done such an incredible job as the first operator in such a, I'm sure it will be a very complex case. And last of all, thanks to our patient, who's done an incredible job also of lying here on the table while we fix his corneas for him. So hopefully he gets a long and very robust result. So thanks very much, and au revoir.